start my case. So it's an interesting case actually. So what we have here is a 44 years old gentleman. He actually a staff working in a Plus Highway. He presented with a 1 month history of intermittent fever associated with mild cough and loss of weight about 5 kilos. So he actually had a positive PTB contact, which is one of his colleagues passed away due to tuberculosis. He's married with 3 children. He denies any sexual promiscuity. He's also a smoker, active smoker for 14 pack years. What you see is actually we already done the blood investigation, and then this is a radiological imaging chest X-ray, which looks pretty much normal, and the full blood counts, renal and liver profile are all within normal range. However, the ESR was high, and CRP also slightly raised. So we also proceed with sputum for gram stain and culture and sensitivity, which turns out negative. Sputum acid fast bacilli times 1, times 2, and times 3 also turns out negative. We send all this investigation because you get a pretty much fast result. The sputum and TB culture somehow afterwards come back after about 2 months, negative as well. Prior to that, we also sent sputum PCR TB to get a faster result, also negative. However, the method test after 3 days and we read actually is positive 18 mm, which is more than 10. So as you can see in the pictures down there, actually by right we have to feel and see for the induration, and when we measure with a ruler, it's actually about 18 millimeters. At this point, what are differential diagnoses? Basically, my top differential diagnosis at this point, looking that the case that we have 44 years old gentleman with a 1 month history of cough, fever, and weight loss, with a recent PTB contact and also positive method test. So looking at all this, the top differential diagnosis is pulmonary tuberculosis. However, other differential diagnoses would be lung malignancy. In view of is a chronic smoker and male on top of that. Other than that, it can be a typical bacterial infection, and down the list would be lung abscess. But that one will happen in those with a low immune system. So in view of the chest X-ray was negative, but high risk of suspicious of TB, tuberculosis. The other investigation that I would like to do is actually to get a CECT thorax. Because chest X-ray might not able to see some certain structures, so that's why the CECT thorax will be much better investigation. Other than that, it might be bronchoscopy to get for bronchoalveolar lavage to screen further for TB. Whether I will start anti-TB empirically at this point, given the history and positive contact, I would say no, not yet. However, in view of high risk of pulmonary tuberculosis, I will try to do my best to expedite to get the CECT scan. And if let's say the CECT scan imaging very highly suggestive of pulmonary tuberculosis, and yes, at that point, I will start empirical TB treatment.
So thank you, Dr. Farhana, for the history and also some of the details of the patient presented. And thank you for the differentials as well. I think those are very relevant differentials that she presented. Maybe before we move on to discuss more on this case, it would be good to get the expert panel's input. Probably we'll get Dr. Andrea to start off with about what are her thoughts on this case, any further investigation that she would prefer.
Okay, thank you. So I think this is an interesting case, and from the presentation, it's very much like the cases that we see routinely, right? So if you go back to the CPG guidelines on tuberculosis that was published in November, about 8 years ago, what they tell you is that you must actually try and culture the Mycobacterium tuberculosis in order for you to make a correct diagnosis of Mycobacterium tuberculosis infection in the body. The supportive thing is actually from imaging as well as from blood results, which is what has been done in sputum results. So if we go back to the original problem, this patient actually had cough, right? So the cough was actually for 1 month.
1 month.
So by definition, 1 month doesn't fulfill the criteria for chronic cough. Chronic cough, the arbitrary timeline is actually 8 weeks. So this is an acute thing. And I think when you have a look at what he has, he's got loss of weight, loss of appetite. TB is a great mimicker. So certainly if I'm thinking along TB and I don't have anything positive, I would also look hard for the alternative diagnosis that can explain what he has. And top of the list would be malignancy, because we see it very frequently. Either you actually have one presents and it leads to the other diagnosis, or you have a concurrent diagnosis. So I think in terms of the investigations, just a little bit about sputum and how to actually diagnose TB. So important point is actually a MEN2 is not confirmatory for active infection. A MEN2 test just tells you that you're recently infected with Mycobacterium tuberculosis. So it's similar to an EGRA. So this patient, if you can argue, you can say, does he have latent TB? Well, you should not put latent TB because he's got symptoms. However, if the symptoms are probably explained by something else, and let's say he turns out to be asthmatic, and the chest X-ray remains clear, and his MEN2 is positive, then he has latent TB. When we look at the sputum AFB direct smear, so the good thing about it is that the turnaround time is very fast. You can get it within the same day. Depends, it's just about looking for the specimen. And it varies in terms of sensitivity, right? So it's certainly not as sensitive as a sputum TB PCR. Cultures go standard. I think we should be familiar with the fact that when you culture someone, there are two mediums that you can culture. One is actually the solid medium, which is the LJ, and that takes a longer time. The other one is actually the liquid, which is the MJ. Okay. So I think because Dr. Patrick will think beyond the lungs, so I'm going to just concentrate on the lungs. Patrick, yes. So I just concentrate on the lungs, and from the lung point of view, because there's nothing else that I want to look for, I would probably look hard to see whether this is actually pulmonary tuberculosis, bearing in mind that it could be extrapulmonary TB. So over to you, Patrick, if that's okay.
Yeah, so thank you very much for the very comprehensive review by Dr. Andrea on tuberculosis, some basic investigations and how do you approach it. Perhaps we can get Dr. Patrick, like what Dr. Andrea said as well, on a general perspective as by infectious disease aspect, how would he approach this patient or this patient?
So I can't say what she said, right? So
Why not?
Yeah, so this one, there's some chronicity to it. So usually acute pneumonia, we think about 1 or 2 weeks. So this one is going on for a couple of weeks, fever and cough with some constitutional symptoms. So I always ask myself, there's a positive contact with TB, so we'll get detailed history, how was this contact, how frequent is the contact, and the fact that the contact actually died of tuberculosis makes me very worried that this patient could TB as high in the list with these constitutional symptoms. And so usually when you are exposed to TB, I usually put a sort of a duration where the risk of reactivation TB is very high. So usually when you get exposed to TB, the first 3 months is a very high risk for you to actually get reactivation of TB. Some people use the 2 years, 1 or 2 years time. So the longer you are from being exposed to TB, that very unlikely that you will get reactivation from latent TB to active TB. So if his exposure has been exposed to a patient, past 3 months and 4 months, the first 1-2 years is very high. The first 3 months is very high. So again, I would like to know that part of the history, that is the case. So then, like what Dr. Andrea said, then we will actually do some investigations for him, because it's still a chronic thing, so I don't expect anything like Klebsiella or strep pneumonia to grow out of this patient. So then I'll see whether it's immunocompromised. So if it's immunocompromised, then the diagnosis is wide open now. We are talking about more chronic infections like fungi, mimicus that presents with lung presentation like Penicillium, histoplasmosis, Cryptococcus, and even Toxoplasma in the lung. Then the rare presentation of CMV or HSV in the lung. So those are the one if it's immunocompromised. So if it's not, then I will see the value of what this AFP means. And so we always try to do proper 3 sputum AFP, but in literature, the best results is actually, we will say maybe 40, as low as 10 to 20, up to 50, 60%. So even if you do 3 AFP, so we have to say, you cannot say this patient don't have TB because of 3 AFP negative. And culture takes about 8 weeks to grow. So we need to make some decision in couple of days time. So then we go on to PCR. So PCR, the sensitivity in an AFP negative is not so good. So some literature has put it down even to 60, 70, and highest you can get is 80%. So if that is your results, you cannot say you can rule out TB. Okay, so in some places in the States, they use 3 negative PCR before they actually take out the patient from isolation room to the general ward. So we are screening by AFB. So they use 3 negative sputum PCR before taking out the patient. So this patient had 1 sputum PCR. So if that is the case, I agree with the presenter, then we may not be a pulmonary presentation. There might be some, maybe extra pulmonary involvement or lymph nodes involvement that CT scan may show you, and hopefully, we always refer to our colleagues respiratory to actually do for us BAL or biopsy if there's something suggestive from the CT scan.
All right. So thank you, the expert panels. So we proceed. Actually, we did the CECT thorax. So in the CECT thorax, this cut here, you can see that it's a soft tissue window. The reason is we would like to show that he actually has a lymphadenopathy there. So from here we can see that there's a right upper paratracheal lymphadenopathy, and then another slice down, there's also enlarged lymph node, like in the circle there. So it's also a right lower paratracheal lymph nodes, and another one at subcarina level. Also, there's an enlarged lymph node there. So afterwards, we proceed with bronchoscopy and EBAS TBNA. We take a sample, and the HP cytopathology actually detected caseating granulomas. So at that time, the culture and sensitivity results are still pending. However, when we recap back, this is a highly suggestive of pulmonary tuberculosis and with a medicinal lymphadenopathy, positive Mantoux test, and also recent PTB contact. So because of this, we actually suspecting of tuberculosis. So we initiated anti-TB therapy. So he was started with 3 tablets of Accurate 4. Based on his body weight. Note that he has no history of allergy. So down there is actually just a picture of Accurate 4 if anyone wonder how it looks like. So at 6 weeks time, however, after he started the treatment, he developed blurry of vision, lethargy, and giddiness. Also noted there's a skin rash and also cervical lymphadenopathy. He also has severe hepatitis, LT up to more than 50 times at 1500s. And he also high bilirubin at 383. So the eosinophils count also raised at 0.88. This is the rash over his leg. So at this point, the rash, when we look at it, it looks like a macular papular rash. Of course, if let's say on palpation, I think it's a blanching. And then some of the rash actually like it groups together. So at this point, my differential diagnosis, number 1, plus he has a hepatitis more than 50 times higher ALT, and then he has a lymphadenopathy. Basically, he has systemic symptoms, involvement, and high eosinophils. So the top will be DRESS, dark reaction eosinophilia systemic symptoms. So other differential diagnosis I have to consider would be Stevens-Johnson syndrome. So of course I have to look at the mucosal layer in the oral cavity, at the genitalia, and also look at the sclera, whether is there any mucosal involvement. And then look how bad is is either SGS or TENS, to see how much the body surface area involved. And then the other thing is it could be just a normal drug eruption secondary to anti-TB, plus with transaminitis because of anti-TB, which is very common. Or it can be just a simple AGEP, which is acute generalized exanthematous pustulosis. However, for AGEP, I couldn't see any pustules. However, this is just a picture over the legs, so have to look hard at the other body area. So at this point, what I would do, number one, of course, to stop the anti-TB medications. And then I have to stabilize the patient, because mind that looking back at this LFT is very high. So I will very much surprised and have to be cautioned, because patient actually in acute liver failure. I think he will be very sick at this point. So
thank you, Dr. Farhana. Yeah, I think the CT scan, initially that we did done the CT scan, it was actually provided a lot of limelight as to what is actually going on for this patient. And subsequently, during the treatment part, we faced difficult challenges where the patient developed hepatitis, the patient developed rash as well. So thank you, Dr. Farhana, for all the differentials on the dermatology aspect as to regards to the rash. Maybe we'll get Associate Professor Dr. Adavia on her comments on the cutaneous reaction to anti-TB.
Thank you, Ian. Basically, the short answer is cutaneous reaction to anti-TB, you can get any type of rash. It is from as mild as just pruritus without rash, and it can be as bad as SJS and TEN. But most of the time, as usual, the most common drug reaction in general is actually maculopapular rash. So similar to anti-TB, actually, it can cause any type of reaction. Even anaphylaxis, urticaria, angioedema, so any type of reaction.
How would be your approach to the management of cutaneous reaction to anti-tuberculous agents?
Right. Okay. So for a drug allergy, is basically the first principle is the same for all kind of drug allergies, not just anti-TB. So identify the offending drug, stop the offending drug. That's all. And management of once the offending drug is stopped, then of course the reaction will also resolve. But however, there is of all the reactions to drug, all will actually stop with the discontinuation of the culprit drug, except for DRESS. DRESS is actually an old term. The newer term is actually DIHS, which is drug-induced hypersensitivity syndrome. The word DRESS has got eosinophilia in it, and most of the time it can confuse people into thinking that you must have eosinophilia in order to diagnose it. But so that's why the term DIHS is more accurate, because the presence of eosinophilia is actually not a must. Okay, so basically you get a drug reaction, you stop the culprit drug, the reaction will resolve except for DIHS or DRESS, because even if the culprit drug has been stopped, the reaction still actually can continue, so they can continue to get worsening of rash, worsening of the hepatitis, or worsening of the AKI. So that's why when we're giving steroids for DIHS or DRESS, the steroid is actually given for longer, even up to 8 weeks.
Thank you very much, Professor Adavia. Maybe we'll proceed with the progress of the case, and let's get Dr. Farhana again.
thank you, Dr. Ian. Okay, so what we have here actually is a blood investigation summary. We have the baseline before patient was started on anti-TB drug, which is pretty much normal. And the 2 weeks after it was started, which on the 10th of February, he actually, we checked the LFT was normal. So, however, after that, he at 6 weeks time is when he started to present with rash. He was very much unwell, and then